طيب السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Thank you, dear friend and colleague, Dr. Saadia, for this kind, introduction. And I would really say اللي هو إنه العمر مجرد رقم إن شاء الله. صحيح؟ I would like to congratulate you, Dr. Hanan, Dr. Manal, Dr. Khawla, for this wonderful, gathering and the success of the 10th, Saudi Society for Rheumatology Conference. And we're looking for, inshallah, the 20th Saudi Society for Rheumatology Conference. I will not take much of your time. I'll try to walk you through this topic over the next 15 minutes. So let's start with this case scenario. Here we have a 29-year-old female who works as a laboratory staff. Her history started in 2018, where she started complaining of pain in her hands, knees, with no swelling or morning stiffness. She had no other symptoms. At that time, she was only showing 4 tender joints with no swelling. Blood work was all negative, including ANA and rheumatoid factor. At that time, she was treated with paracetamol on PRN basis. In 2019, she started to complain of worsening of her pain in her hands as well as knees. She was also reporting occasional swelling, again with no morning stiffness and no other symptoms. There were no swollen joints, but the count of tender joints was increasing. At that time, she tested positive for ANA at a titer of 1 to 80 in homogeneous pattern. She was treated with NSAIDs and was referred to rheumatology. 2 years later, after the COVID-19 lockdown, she presented with classical inflammatory arthritis. She was also having fatigue, and she was also showing episodes of oral ulcers. At that time, she had 3 swollen joints along with 7 tender joints. And if you look at her titer actually increased from 80 to 320. And at that time, she was seen by rheumatology for the first time. So hydroxychloroquine was added into her treatment regimen in an attempt to treat her inflammatory arthritis, as well as to control the oral ulcers with the help of hydroxychloroquine. 1 year later, she presented with, again, inflammatory arthritis, malar rash, hair loss, fatigue. At that time, she tested positive for anti-double-stranded DNA, and she also had thrombocytopenia. And prednisone was added into her treatment regimen, and hydroxychloroquine was continued. So ladies and gentlemen, I walked you through a patient who was healthy at the beginning, and then she turned ANA positive with no clinical features suggestive of an underlying systemic rheumatic disease. Then she progressed in 2021 to a UCTD based on inflammatory arthritis and positive ANA. And then in 2021, she started to have like the early phase of systemic lupus erythematosus with the classical clinical as well as serological features. So this clinical progression is definitely coupled with some immunological progression. So let's do some show of hands. How many of us have patients in our practice who have undifferentiated connective tissue disease? Please raise your hands. So I think the hall is like full of audience. Keep your hand raised for another like few seconds. How many of you have 5 patients with undifferentiated connective tissue disease in your practice? Please raise your hands. Now keep your hand raised. How many of you have 10 patients with undifferentiated connective tissue disease? So the higher the number that I'm going, the lower the raised hands we're having. So as Dr. Saadia mentioned, it's a challenging disease. It's kind of like an orphan disease, but there is something that keeps this disease in its position and it's not progressing. So the questions that we usually face when we see these patients in our clinics, whether or not, why did my patient not yet progress from a UCTD to SARD? Is my patient going to progress from a UCTD to SARD? And is there anything that I can do to halt the progression for this patient from UCTD to SARD? So what we're going to do over the next few minutes, I'll quickly go over the autoimmunity for us as rheumatologists, and then I'll also provide you with some overview of UCTDs. And then we will try to answer this question: do all individuals progress from UCTD to SARD? And then we will also try to address this point of whether or not there is a need for biomarkers to monitor progression from UCTD to SARD. So we all know that autoimmunity is an exaggerated activity of the immune system. It's basically loss of self-tolerance. So we become like, victim of our immune responses. This can be either antigen-driven process, such as, like infection, then that infection leads to autoimmunity, or autoimmune process itself because of the presence of the autoantigens. Now, because of this, we tend to have loss of previously established like tolerance. And examples, we can have, for example, organ-specific autoimmunity, such as autoimmune thyroiditis, autoimmune hepatitis, Addison's disease, myasthenia gravis. So these are all, autoimmunity that is, specific to an organ. Or we can have systemic, such as, the diseases that we deal with in our practice, such as systemic lupus, systemic sclerosis, and so on. Now, there are stages of the immune or of the autoimmune disease. So each autoimmune disease starts with the very early phase, in which we tend to have like some genetic mutations that leads to the establishment of the benign autoimmunity, in which we start to see some autoantibodies without any clinical features suggestive of like an underlying, connective tissue disease or systemic rheumatic disease. Then this stage moves on with the continuous like production of the cytochemokines and the activation of the autoantibodies into the incomplete, or I would say like UCTD, in which we tend to have like few features that are suggestive of an underlying systemic rheumatic disease, few autoantibodies, but they do not fulfill criteria of an underlying disease. And then, of course, the later stage where we tend to have like a classifiable systemic autoimmune rheumatic disease. Now, if you remember from your medical school, residency, as well as fellowship, we have few mechanisms by which, the autoimmune or the immune system is turned on, and then it goes into the autoimmunity. So first of all, we have the molecular like mimicry, in which the similarities that tend to happen between the self peptides as well as the foreign peptides are recognized by the immune system, and this leads to the activation of the T or B cells. So this is one mechanism. The other mechanism is the epitope like spreading, in which we tend to have like development of the immune responses to the endogenous epitopes secondary to the release of the self antigens. There is another mechanisms by which the autoimmunity is turned on. We call it bystander activation, in which bystander means واحد قاعد مستني. He's just looking after you. So bystander activation is the activation of T cells without, the presence of the antigen recognition. And of course, we have the, the cryptic epitope exposure, in which we have epitopes that are in form of MHC class 1. They don't tend to have like the T cell component in them, and they do not, delete the autoreactive T cells, which in turn leads to the activation of the autoimmunity. Now, we all remember the fire triangle: heat, oxygen, and fuel, without which you cannot actually burn like a fire. The same concept actually applies to the autoimmunity, where you have to have the triangle of autoimmunity, which is composed of the immune, changes that tend to happen in the body, secondary to some genetic, mutations, and these two wait for the environmental factor to complete the triangle, because of which we turn to have like the autoimmunity or the fire. How about UCTDs? So UCTDs tend to have serological and clinical manifestations of an underlying SARD. However, they do not fulfill any criteria that is defined for a SARD. It's a diagnosis of exclusion. 90% of patients are female, unfortunately, between 30 to 40 years of ages, and of course, majority do not progress to a full-blown picture of a SARD, and they tend to remain stable over time. Now, we have 3 consecutive phases. So we have the initial phase of the UCTD, in which we do not see any clinical or serological findings. This is what we had in our patients back in 2018 and 2019, because you might be challenging whether or not, an ANA titer of 1 to 80 is considered really positive in our, population. Then we have the subsequent phase in which we do not see any clinical findings, but we tend to have a positive serology. Then we have the final phase. We tend to have clinical and serological findings of a possible underlying connective tissue or systemic autoimmune rheumatic disease, however, not fulfilling the criteria for a diagnosis. From 1999 until today, we continue to have this preliminary criteria, and we have not had any updated criteria for the diagnosis or detection of undifferentiated connective tissue disease in our patients. These criteria state that you have to have signs and symptoms suggestive of connective tissue diseases, but not fulfilling the criteria for a defined SARD. And of course, you have to have the presence of ANA on 2 different occasions. Some also say you have to have a presence of anti-U1 RNP antibody as well. Now, what are the clinical features that are seen in patients with, undifferentiated connective tissue diseases? So approximately 85% of our patients tend to have musculoskeletal manifestations such as arthralgia and arthritis. Then, of course, not to forget the second most important symptom for us as a system, for us as rheumatologists, the dermatological. Approximately 50% of UCD patients tend to show some dermatological manifestations, followed by features in the head and neck. So, for example, iritis, uveitis, or oral ulcers. And of course, malar rash. I don't know why did I put Raynaud's phenomenon there, but I apologize. ممكن يكون في Raynaud's phenomenon for the nose, right, Dr. Rajai? So just take it, يعني. Anyway, then of course the gastrointestinal manifestations, when we tend to see some organomegaly, not to forget neurological manifestations in approximately 7% of our patients who tend to have small fiber neuropathy or some CNS abnormalities, and of course cardiopulmonary can tend to happen in approximately 15% of our patients, and constitutional symptoms as well as cytopenias are noted in up to 20% of patients with undifferentiated connective tissue diseases. Do all individuals progress from UCTD to SARD? So what would determine this progression? It could be related to the expansion of the pathogenic autoantibodies. So an autoantibody or an ANA titer of 1 to 80, if it progresses and increases to, for example, 1 to 320, 1 to 640, 1 to 1,280, is this significant clinically or not? Is this going to be coupled with progression in the clinical phase as well of the disease? How about some other factors such as decreased, regulatory T cells? So T cells, or the regulatory T cells, are the police of our immune system, which means that the higher, the percentage or the number of the regulatory T cells in our, body, the less are the chances for the development of the autoimmunity. So it was noted that patients with UCTD tend to have higher, numbers of regulatory T cells compared to those with SARD. And of course, rising levels of circulating pro-inflammatory cytokines, and that will be shown in the next, few slides. So time-dependent expansion of the pathogenic, autoantibodies. Yesterday, we have seen a beautiful lecture by Professor Umair in which he was talking about the preclinical RA, and we can see that, for example, anti-CCP is elevated years before, the onset of inflammatory arthritis in patients with rheumatoid arthritis, and of course, the presence of high titer anti-CCP was also linked to some, cytokine changes in the circulation in patients with preclinical rheumatoid arthritis. How about the cytokines? So what are the cytokines that we tend to see in patients with, preclinical or, UCTDs? We presented this abstract in 2016 at the ACR, in which we had approximately 150 patients, out of which we had healthy controls. We had ANA positive individuals without any symptoms. We had 28 patients with undifferentiated connective tissue diseases, and the rest were early SADS, which means that they were within the first few years of their systemic sclerosis diagnosis, SLE, Sjogren's, or mixed connective tissue disease / dermatomyositis. What was noted that, for example, cytokines such as IP10, eotaxin, as well as TNF-alpha were significantly, elevated in patients with early SART compared to those with ANA positive or UCTDs. So it means that if our patients with undifferentiated connective tissue diseases tend to have these cytochemokine abnormalities or elevations, they're actually at risk for the development of an early SART. However, we have to keep in mind that this was a cross-sectional study, so we cannot really generalize, and more, perspective and cohort data are needed. Few other cytokines in other diseases, such as rheumatoid arthritis. So we have of course, the GM-CSF, we have interleukin 12, we have interferon alpha, as well as, the other interleukins that are also linked to the progression of a UCTD to a full-blown picture of SART. So checking these cytochemokine changes might help identify patients who are at risk for the progression of connective tissue, undifferentiated connective tissue disease to SART. Do all individuals progress from UCTD to SART? So why don't our patients progress from UCTD to SART? Obviously not. Why is that? Because as we have pro-inflammatory cytokines, we have the anti-inflammatory cytokines that actually pull the immune system back, from progressing to a full-blown autoimmunity. We have also regulatory cytokines who actually, regulate up or down the immune system, by which trying to prevent the immune system from, continuing to the full-blown picture of an underlying SART. And of course, the introduction of the DMARDs in the earlier phase of UCTD might help halt the progression of UCTD into a full-blown picture of SART. A study that was, conducted in 2016 to address some cytokine profiling in patients with preclinical lupus showed that patients who continued to be preclinical, either ANA positive or UCTD, they tend to have elevations in these cytokines compared to those who had lupus. So it means that we have cytokines that, break or slow down the progression of the immune system into the full-blown picture of SART. And of course, increased levels of, for example, type 1, interferon signatures, BLyS, as well as interleukin 12, increase, the progression of the disease. So which of your patients will progress from UCTD to a SART? It's worth to mention that 60% of UCTDs remain undifferentiated. So it's kind of reassuring. Others might progress to SART. Are there any predictors that can help us identify those who are at risk for progression? Yes. So patients who tend to show cytopenias, these are the ones that might progress. Patients who have changes in the nail fold capillaroscopy. Yesterday we had a wonderful workshop by Dr. Fawad, in which we saw patients who were having abnormal nail fold capillary. So it's really important to train on the nail fold capillaroscopic assessment. It's an easy, non-invasive bedside procedure that can be done. Or patients who tend to show elevations in their ANA titers. And of course, the first 5 years of our patients' disease course are the I would say the critical period in which they will either progress or not to progress to SART. The last point that I will cover in 1 minute: is there a need for a biomarker to monitor progression from UCTD to SART? Of course, because this would present a significant therapeutic opportunity, as we just saw in the previous slides, that identifying some cytochemokines that increase the chances of progression might help us target these cytochemokines and then prevent the disease from progression. Of course, treatment in the preclinical or UCTD stage can possibly attenuate or inhibit disease progression. And there continues to be a short but growing list of potential disease defining biomarkers, for example, such as platelet factor 4 was noted to be elevated in patients with early diffuse systemic sclerosis compared to those with established disease or SLE. So for example, if we tend to have elevation of the platelet factor 4 in the UCTD phase, we might, predict that this patient is going to develop either, systemic sclerosis or early SLE. The same thing applies for other, biomarkers such as microRNA signature, as well as BAF, which is shown to be elevated in approximately 90% of patients with SLE and systemic sclerosis, compared to those in rheumatoid arthritis that is elevated in only 20%. And of course, identifying these biomarkers will help us identify potential target for therapeutic intervention. So ladies and gentlemen, Mr. and Mrs. Chairperson, if you allow me to summarize my talk, and I would say that UCTD is a stage in autoimmunity with rich field for research and innovation. Clinical practice guidelines or recommendations are not defined yet, and potential areas of intervention and precise definition of UCTD are all, still unmet needs. Identification of druggable biomarkers may provide therapeutic targets that may halt the progression to SARD. With that, I come to the conclusion of my presentation. I would like to thank you for your kind attention and listening.